Morning. I'm Michelle Levander, editor of Reporting on Health. We're going to be speaking today about the rise of the hospital giants, a dramatic increase in hospital consolidation, which threatens to lead to rising costs and less competition. Since the passage of the Affordable Care Act, we've seen big hospitals swallow smaller rivals and doctors sell practices to hospitals. Insurers are losing negotiating power, threatening to lead to an era of rising hospital costs. Margot Sanger-Katz, who covers healthcare for the New York Times The Upshot, and one of our speakers today, calls these giant hospital chains the new Goliaths. Professor Paul Ginsberg, the Norman Topping Chair in Medicine and Public Policy at the University of Southern California, our other speaker today, believes that a robust healthcare market and competition is more important than price transparency to curb runaway healthcare costs. Professor Martin Gaynor could not join us because of a family emergency. Margot will be discussing some of his material. Before we get started, I wanted to share a few operating procedures. We'll hear first from our speakers, who will each give a 20-minute briefing, followed by a discussion. Then we'll open it up to your questions. Because we have several hundred people participating in the webinar, we'll ask you to comment in the question field in your control panel, and then we'll call on you and take your questions for the final 20 minutes. If time permits, we'll also ask participants to raise their virtual hand, also in the control panel, and then call on you directly. You can tweet about this webinar at #HealthMatters, and we will archive it afterward on Reporting on Health. Now let's get underway. Margot, tell us about this new hospital landscape.
Hi, everyone. I'm just going to cue up my slides here. Yeah. Okay, hopefully that works. So I just wanted to start just describing the trend that we're seeing right now, which is you can see on this chart, in the 1990s, there were quite a lot of hospital mergers that happened, and then there was really a decline. And through most of the 2000s, you can see there weren't nearly as many. And now we've seen a real acceleration starting right around the time that the Affordable Care Act passed. 2010 was kind of a big year, and it's been on the rise since then. And indications from surveys of hospital executives suggest that there's still a long way to go. And these numbers don't capture what's happening with physician practices, but there's quite a lot of evidence that physicians are increasingly selling their medical practices to hospitals. So there's kind of two types of consolidation that are happening. One is this, hospital-hospital mergers as hospitals are joining together to form bigger operating units. And then there's also this kind of physician-hospital merger phenomenon that's also happening as physicians join up with the hospitals nearby. And I think the big question is, why is it happening and why has this trend accelerated recently? A lot of hospital executives will say that the Affordable Care Act is the reason why they did it. I think it's important to realize that the law itself has very little to say about the size of hospitals. It's basically agnostic. It doesn't say that bigger hospitals are better than smaller ones, but there are a lot of things about the world of health policy that are changing, both because of the Affordable Care Act, but also because of other recent health policy changes. And I think that environment helps explain some of the reasons why we're seeing some of these changes. So here are a couple of those policy changes that I think are useful to know about. One is actually a law that passed before the Affordable Care Act called the HITECH Act. And that's the law that essentially encourages hospitals and physicians to obtain electronic health records and to meet certain standards about data sharing and use of those records to try to guide the way that they provide care. And you hear a lot from hospitals saying that, buying and implementing and running these records is actually a pretty big burden, and it can be hard for smaller organizations to do it. One of the reasons is it's a little bit harder for them to borrow money to buy health records than it is for them to borrow money to do other kinds of capital expenditure. The law itself, has increased the measurement of quality, and there's more kind of pay for performance. So this is not a huge part of how hospitals are paid now by Medicare, but it is kind of happening around the edges. Things like hospital readmissions, for example, which have, hospitals are increasingly being penalized if people that they let go come back within a short period of time. And I think there's a view that trying to measure this kind of information, report it to the federal government, and also try to develop systems that will help them reduce the things that could result in penalties also is harder for some of the smaller organizations. The law set up a whole bunch of different new models of payment for hospitals, and most prominently the Accountable Care Organization. And basically the Accountable Care Organization is like a supersized version of what I've just described, where it tries to create incentives for a hospital to take care of like all of the patient's needs and to get incentives, to get sort of paid bonuses based on the quality of care that it's delivering and also based on the total spending of that patient. And you hear from a lot of hospitals saying that if they want to participate and form an ACO, that they really need to be able to control all of the different players that take care of their patients so that they can, first of all, coordinate care between the various doctors and other entities that care for patients, but also so that they can kind of share data and have aligned incentives. Now, that doesn't always happen, but you hear them talk about ACOs, and organizations that are forming ACOs do tend to be part of this trend. And then there's just kind of the general payment environment right now. The Affordable Care Act reduced hospital payments from the Medicare program, and it also reduced certain supplemental payments that hospitals that used to treat a lot of uninsured people got through the Medicaid and Medicare programs called DISH payments. And that's a really complicated technical thing, but I think the basic message is that government payments are declining for hospitals, and so they're just kind of feeling the pinch. And so the hospitals that were having difficulty financially in the old environment may feel more stress and may feel more of a desire to merge with a larger neighbor than to try to kind of eke it out in this environment. And then the last thing I would mention is Congress just recently passed a new bill that changes the way that Medicare pays doctors. And some of what it does is similar to what the Affordable Care Act did for hospitals. It increases the amount that doctors can be rewarded and punished based on the quality of care that they're delivering. And the exact details of how that's going to be measured still have to be worked out. But I think, we may see some doctors feeling like this is too much pressure, they can't manage these kinds of metrics, and they want to be part of a larger organization. That bill also, as I understand it, creates some pretty explicit pay incentives for doctors that are part of an ACO or some of these other new organized payment systems. And so I think both of those things may contribute to what we're already seeing, which is this trend of physicians moving into hospital employment. And then there just are some other things that are not related to the policy environment, but that I think are relevant. One is just, when there's a lot of mergers going on, I think sometimes hospitals kind of feel this musical chairs anxiety. They're worried if they wait too long, then there won't be a good partner for them, or they'll be the only one standing and they won't be able to compete. On the physician side, I think a lot of doctors who come out of medical school and residency now are less interested in running their own business, in taking a lot of call, and they may just prefer to be a salaried employee of a larger system. So I think more of them are kind of looking for those kinds of jobs. The way that both Medicare and a lot of private insurance pays doctors sometimes rewards doctors that do similar services in a hospital environment to if they did them in a private practice. So the rationale for that is that hospitals have a lot of additional overhead. So if you're giving someone a stress test, say in a cardiology office, and it's owned by the hospital, that the hospital should get a higher payment for that to help supplement all the other things that a hospital has to do that a freestanding practice doesn't have to do. But the result of those differences is that sometimes being a part of a large hospital system is a way that a medical practice can actually collect more revenue. And that seems to be having the biggest effect in cardiology, where a very large percentage of cardiologists have moved into hospital practice, and also in oncology and cancer care, where hospitals often can get really good discounts on cancer drugs and then can capture more of the payment that they get from the government payers. We hear a lot about this new idea of narrow insurance networks, especially in the new insurance plans that are being sold on the Obamacare exchanges. And I think some of the smaller players are saying sometimes it can be harder to get a contract with one of these insurers because they just want to link up with one or two hospital systems. And so if you're not part of that system, then you can get left out. I think those narrow networks, I think Paul's going to talk about more, and it could sort of cut both ways, but that is something that they talk about. And then there's just a simple reason, which has been historically why we've seen a lot of mergers and why a lot of those mergers were happening in the 90s. And that's that large organizations, generally speaking, have an easier time negotiating with insurers to get better prices. And you actually, often you don't hear hospitals and doctors talk about this, but more often than you would think, you actually do hear them say, we're too small, we're just in a bad negotiating position. If we can join up with a larger organization, then we're going to have more power in the market. I wanted to suggest some good stories to read just for inspiration. I think, well, one of these stories is my story, but the other ones I think are all just kind of amazing deep dives into one local market that shows how consolidation has changed the way that healthcare is delivered and has affected consumers. So one is this Boston Globe series from several years ago that looked at the partner system, which is the very big hospital system in the Boston area. and it showed how they're able to command substantially higher prices than other hospitals. And Partners is kind of an interesting system because they control a lot of the hospitals and doctors in the area, but also they have a couple like really high profile famous hospitals, and so it's very difficult for insurers not to do business with them, and I think that gives them a lot of power in that market. There's a great Charlotte Observer series. It was a finalist for the Pulitzer Prize a few years ago that was looked at what's happened in North Carolina, where there are a couple of very large hospital systems, and it also looked at the effects of physician practices joining these hospitals and what was happening to consumers. There just are some really good stories about patients and how they were affected by these changes. The New York Times has done this very big series about the cost of healthcare, and one of the stories, which I've linked to here, looked at the Sutter Health System, which is interesting. It's in California, and instead of being kind of locally concentrated market, what Sutter has done is they've sort of bought up hospitals around the state. And if Marty was here, he would talk about what the implications are for antitrust, but it's a little bit harder to regulate those kinds of mergers, but it seems to be having a similar effect, which is prices are quite high among those hospitals. And then my story is from a couple of years ago, but it just sort of looked at, what do we know about what these mergers likely mean and kind of what's the shape of the trend. So I'm going to impersonate Marty in a minute and go through some of his slides, but that story may be like a slightly breezier way through some of the existing research about what we know about the effects of mergers. I wanted to suggest some story ideas. Obviously cover what's happening in your local market. What are the explanations about why mergers are happening? And, I just would, really dig down and see whether they seem reasonable and how they match up with the evidence about what we know large organizations do better and don't do better. There are some special cases that are interesting. Rural hospitals seem to be in particular financial trouble, and they are particularly eager to find partners in a lot of markets. It may be worth, if you have a lot of rural hospitals in your market, really looking at them particularly. And again, as I mentioned with Sutter, I think the mergers of hospitals that are kind of geographically diverse are interesting, with displaced are interesting and different. Again, like the physician practice acquisition is interesting. That affects a lot of patients, and it does change the way that medicine is delivered. And it's just something you can kind of see in your market as physician practices get bought up. And it may be interesting to see if there are particular specialties that are remaining independent and others that are tending to get purchased. As I said, I think cardiology and oncology, there's been a lot of movement. Increasingly, I think primary care practices are tending to come into these hospitals because the hospitals think they're important for doing these ACOs and other kinds of coordinated care. But there are other kinds of specialties that are having a little bit more luck staying independent. It's maybe worth digging into why that is. ACOs, again, this is like a big push by the Obama administration. It was in the health law, and the administration has, indicated that they would really like to see more care delivered this way. The evidence so far has been very mixed about their performance. Some of the ACOs seem to be doing a great job delivering high quality care and doing it for cheaper than their competing institutions, but other ones have not performed so well. And I think it is useful if you have ACOs in your market to really dig in and think about whether they are delivering on the promises that they made when they formed, and like what the challenges may be for them if they're not. There are great consumer stories to be done about this. If healthcare prices are rising, which is often the case in highly consolidated markets, that affects people who don't have insurance, obviously, but it also affects people who do have insurance because they're paying more out-of-pocket costs often for co-insurance and co-payments, and if they have high deductibles, they're paying for that too. I think it's worth looking at what's happening with charity care. The North Carolina newspaper series did a really good job of showing that these very large hospital systems, even though they were nonprofit, were not delivering very much in the way of charity care, and that may be true in other markets too. And then another thing that I think is interesting is, again, as these organizations get really large and are trying to take on risk, some of them are starting to form their own insurance companies and selling plans either just for Medicare patients or on the exchanges or in other markets too. And I think that's, that's kind of an emerging trend that's interesting. And if you have that in your market, I think it's worth looking at why that's happening, how that's happening, and whether these hospitals are really well equipped to make this transition. Marty and Paul are great experts. Marty's not here, but I'm sure he's always been wonderful to me, and I think he could be a great source. So, talk to the experts. But here's some other sources that I think can be useful. This first group of organizations are all places that track mergers and acquisitions. So if you want to get more updated numbers than were in my chart, or you want to look at particular markets, they can help you. The health insurers are very worried about this. They feel like these large organizations are hard to negotiate with and lead to high prices, and so They are often really good sources of information and sort of opposition research about what's happening, but obviously be aware of their bias. They are, the natural opponents of hospitals, and they want to make them look bad. Patients are great, especially if you want to write about the consumer impacts of these stories. Talk to people, find out what they're paying, find out how their experience has changed as their practice or their hospital has moved into a different organization. Ask for their bills. It's always useful to talk to the independent docs about what pressures they're facing. Are they feeling this kind of musical chairs, pressure to merge or to be sold? And national and local medical specialty societies are also often helpful in just understanding what the dynamics are, especially because some medical specialties and some kinds of hospitals are experiencing more pressure than others, and often they can kind of tell you whether they are the ones that are experiencing it or whether it's other people. There's some links to different kinds of hospital financial documents, but they often will tell you how hospitals are performing, and it may be useful to look at the big hospitals relative to the small ones that have remained independent. And then on prices, historically there hasn't been very much information, but actually is a little bit more than there used to be. A couple of states have these new all-payer claims databases where you can actually look at some of the prices that are being paid for medical services, and you may actually be able to observe changes or compare markets depending on who is consolidated and who is not. There also are a growing number of these sort of crowdsourced price data organizations. There's one called Clear Health Costs. I may get that wrong. I could email Michelle afterwards with that source. But in some places, there are other bits of information that you can get about prices that may be useful. Feel free to email me. I'm happy to be helpful. Here's my contact information. And now I'm entering the part of this presentation in which I impersonate Marty Gaynor, which is dangerous. You should know he's a wonderful expert in all of this. He's studied the effects of consolidation for many years, and he also recently finished a stint at the Federal Trade Commission where he was investigating mergers that were proposed and trying to make decisions about how to enforce the laws. But he's just come back to academia after a couple of years of doing that. And, so here are his slides. I think the main argument that he would make is that we really do rely on healthcare markets to keep the quality of healthcare high and to keep healthcare affordable, because as different providers compete with each other, they're more likely to lower their prices or keep them reasonable, and they're more likely to try to do a better job because they want to try to compete with other hospitals in the area, and that as there's more consolidation, sometimes those pressures disappear. At the same time, we do have problems in the U.S. with a fragmented healthcare system. So if no one's talking to each other and no one's working together, that's bad too. So, good public policy is sort of balancing those things. Related to that, there are these possible benefits of consolidation that you hear the hospitals talk about and are worth thinking about, which are we need to coordinate care better, and we can't have all of these disparate parts of the healthcare system not talking to each other. But just because hospitals get big doesn't mean that they're necessarily doing those things, and it's important to distinguish between just scale and size and these real kinds of coordination. I'm just going to quickly go through this, but he has done this really great bibliography of studies on the benefits of consolidation, whether or not they're working. The general, I think, thrust of a lot of this is that sometimes there are benefits, but very often prices go up when markets get more concentrated, and quality often actually goes down. These are examples of particular ones. And then here's his overview of who regulates these things and what are some possible solutions. I know Paul's going to talk more about this, but I think the important thing to realize is that the federal government, through the FTC and the Department of Justice, does look at large mergers in advance, and they will sometimes intervene to try to stop mergers that they think are genuinely anti-competitive, but they have sort of limited jurisdiction. There are only certain kinds of transactions that they can look at, and they don't always win in court. And that once these transactions are closed, there's very little that they can do after the fact to try to fix the markets. And so if you saw that chart of all those mergers that have already happened, there are a lot of places in the country where you already see very concentrated markets, and antitrust enforcement is probably not going to have a lot of impact there. All right, on to Paul.
Thank you so much, Margot. Paul, we're going to turn to you now and have you talk a little bit about where we go from here now that we have this excellent look at the landscape.
Great. My talk is really focused on how do private sector entities and governments address some of the ill effects of consolidation. And so I begin with a slide I do not have to cover. I kind of titled it the mergers and consolidation driven by fear as well as greed, but Margot did a really wonderful job in much more detail, really showing what some of the motivations for merger are. And my bottom line is like her, there are a lot of fear aspects of it as opposed to greed, that there are legitimate reasons why many providers are pursuing consolidation. Now, the record on hospital mergers is quite well known, and Marty Gaynor has been written some of the most influential things about the degree to which mergers among hospitals have led to higher prices for insurers and patients, and also have not had a positive effect on quality. It seems to be undetermined. The FTC, it was well known during the 1990s particular, was very unsuccessful in challenging hospital mergers, just lost a number of cases in a row. And that has turned. And I think one of the reasons it has turned is that there's a lot more research on the effects of hospital mergers. And this is very helpful for the FTC to point to. They're on a winning streak now. Had a number of very successful challenges of horizontal mergers. One thing that really is just coming up is the concern about vertical integration, or basically hospital employment or acquisition of physician practices. It's obvious that this leads to higher payment rates for physicians and perhaps for hospitals as well. But besides that, it's a concern about being a barrier towards steering patients to higher value hospitals if the physicians are all aligned with the hospitals. And also it reduces the number of potential competitors who can compete in this ACO risk contracting market. So I'm going to spend most of my time on market approaches, government efforts to facilitate market approaches, and a little bit on direct regulation of prices, which I don't get into very much. Okay, and I want to start with an obvious market thing, which is providing better information on price and quality for, I should have said patients, enrollees meant enrollees of health plans, as so many patients are. And as far as online tools for employees to get information about price and quality, I think there's been enormous progress, particularly on the price side, in giving consumers, or I should again say enrollees, very relevant information. But studies by the Catalyst for Payment Reform shows that the rate of use of these tools to date has been very disappointing. Realistically, I think most of the opportunities for these tools to foster more competitive purchasing by patients are on the outpatient side. And the reason is that in today's benefit designs, there are very few incentives for patients on the choice of inpatient setting. Even if they have high deductible plans, a hospital stay almost always exceeds the deductible, may very well get to the out-of-pocket maximum, so that it doesn't really cost the patient more to go to an expensive hospital versus a less expensive hospital. And also there are legitimate barriers to getting patients' price estimates for an inpatient episode because we don't pay on an episode basis. We're still paying by the service, occasionally by DRGs or per diem. So I think the hospitals are really not in a position, just the way hospital care is paid for, to give a firm estimate to patients. And one thing I want to mention that's coming up more and more is there's an inherent conflict, I think, between approaches to competition, which emphasize, price and quality information for consumers, and the approaches that emphasize greater integration and coordination of care, population-based care. It really comes down to, do people want to purchase healthcare on an a la carte basis, and with good price information and hopefully quality information, choose exactly what they want, or do they want to really have a fixed price meal and really, choose a system to align with and really rely on them to coordinate care and to steer them to providers who would be most useful for their needs. I think limited networks are perhaps the most powerful market approach. I think a lot more powerful than price and quality information for consumers. And limited networks lead to lower prices in two ways. One is steering patients towards the providers with the lower prices, and also increased leverage on the part of the health plans. Many anecdotes reported about providers lowering their prices, either overall or often specifically, to become part of a more limited network. And this is really how it's designed to work. I believe that limited networks can be very effective in markets that are fairly concentrated, as well as those that are more competitive. I mean, clearly they're not effective if there's only one provider in the market, but you could have a dominant provider and offer unlimited network products with, say, all or most of the other providers, and that can really get traction, have an impact on the overall market. I think limited networks are far simpler for patients than price transparency. They don't have to do a lot of research on an insurer website or elsewhere to decide who has the lowest prices for them. They've committed themselves to a limited network, and it doesn't matter very much which providers they go to. I think exchanges, both the public exchanges and the private exchanges, create an ideal incentive structure to use this approach more extensively, because basically enrollees, if they choose a more expensive plan, they pay the full additional premium. No one is subsidizing it to them. And it's also ideal because it avoids the one-size-fits-all requirements that most employers face. That in employer plans, they want the network in the plan to satisfy a very large proportion of their employees, or that's not going to work. But in an exchange environment, you can have a plan that is very attractive to 30% of the population that's using the exchange, and that could be a very successful plan. So in a sense, it frees insurers from this one-size-fits-all requirement. Now, there's a major regulatory threat to the approach of limited networks. And the fact that there is a regulatory threat will not surprise anyone. This is political economy 101. That this approach obviously disadvantages providers, and also there are consumer advocates that are concerned that it won't be done well, choice will be insufficient. And so it's very tempting for policymakers to, I think it's actually very appropriate to have network adequacy rules, but there's really a potential for it to go too far and actually shut down the strategy. Those initials I have, AWP, stands for any willing provider, which is laws that some states have. Many of them go back to the 1980s, which basically says that any provider who's willing to meet the terms set by the insurer can demand to be included in the network. So far, I think the regulatory threat has been muted. And I think a reason for that is that the affordability issue in healthcare is so much more prominent. Healthcare spending is so much larger in relation to people's incomes that the notion that Overregulation by network adequacy and any willing provider can cost consumers a lot of money. And there are many consumers that basically would like to be able to save that money and are willing to have less choice. There's a pressing challenge for insurers, which is network transparency. Obviously, for a limited network approach to work, both in consumers when they're choosing a health plan and patients when they're choosing a provider need really good, accessible information and accurate information about which providers are in the network. So far, insurers have not done well, and it's not easy to do. I think insurers are putting a lot more resources into it, at least I hope they are, because this is a major vulnerability. If people throw up their hands and say, I just can't deal with this because the information is always so inaccurate or so hard to get, I think that's going to be a vulnerability of the approach. So I think that insurers are going to have to devote more resources to making the directories more accurate, and they may even have to go to different types of network contracting so that the network is more stable, and so that when people enroll in a plan, they can have confidence that 5 months later, if they get sick, the network will be roughly the same. One topic that's often joined with discussions of limited networks is what we call surprise balance bills. These are basically physicians that patients do not choose, such as ED physician and anesthesiologist, an assistant surgeon, turning out to be out of the network even though the main physician and hospital are in the network, and so the patient gets a surprise balance bill for an additional charge, which often can be quite large. I think this is not an issue limited to limited networks. It's really one that affects broad networks as well. And there's a market solution to this, which is to have health plans, and I think some of them are doing it, to incorporate into contracting with hospitals a requirement that the hospital provides in-network anesthesiologists, radiologists, say ED physicians, for when the enrollees access their hospital. And we've also seen regulatory approaches, often at the state level, to limit charges that such out-of-network physicians that patients don't choose can charge. And the limits are usually some percentage of Medicare rates, it's something significantly over 100%, but a lot lower than what some of the charges actually are. Now I want to talk about tiered networks. And tiered networks basically are networks that are broad but have an incentive within the network that some of the providers are going to be seen as preferred, and the patient will pay less as far as cost sharing for using them. I'm expecting that ultimately tiered networks will have broader appeal than limited networks because patients will have more choice. So patients would be making point of service decisions on whether to go to a provider in the preferred network and the not preferred network or out of network, rather than making an annual decision to commit themselves to a more limited number of network providers. I think there's potential for, when I look at the popularity of preferred provider organizations historically compared to health maintenance organizations, and also how in prescription drug benefits, tiered formularies are far more popular than closed formularies, which only include a limited number of drugs. But I think one of the reasons why tiered networks have not progressed very much is a number of activities by prominent hospitals in various markets that have included anti-steering clauses in their contracts, which means our contract with you requires you to list us in the preferred tier, or all or nothing contracting by prominent hospitals, which says, we have 10 hospitals, there's one that we know you want, but you need to contract with all of our hospitals or we won't contract with you. Massachusetts in 2010 passed a law that barred anti-steering clauses in contracts, and the state had already been pursuing this tiered network approach through actions of the General Insurance Commission, which provides coverage for state employees and some local employees. And what appears to have happened is that the 2000 law led to a blossoming of tiered networks in Massachusetts, particularly prominent in the small group market. I think tiered networks have fewer obstacles with physicians, although physicians have often been unhappy. Sometimes the term high-performance networks are used because the physicians have often challenged the plans on, do you really have good enough data to decide which of the physicians should be in this preferred network? Reference pricing, which is pretty well known, is really a more aggressive approach to tiered networks. But a problem with reference pricing is it applies to a much smaller share of spending, only services which are, quote, shoppable, unquote. And a shoppable service basically is where the patient has a lot of time to make a choice. And then the patient knows what he or she needs as far as a service. CalPERS experience with joint replacement is very well known. It was a very successful experience, although it was hard for them to do. And they did a lot of work on, with a lot of quality data on ensuring that the reference pricing offered many notable hospitals who had good quality data on joint replacements. It was a very small percentage of their spend, though. I think reference pricing, and I should have said it, reference pricing means that the insurer will not pay more than a certain amount, and that amount is usually determined by, perhaps the median price under its contracts in the market. So I think that reference pricing works best for discrete outpatient procedures, such as an MRI or a colonoscopy. And the big challenge, which was not experienced in joint replacement because patients needed authorizations for joint replacement surgery, is just alerting patients that, there's a reference pricing policy and you should pay attention to it. Another approach by both the market and policy is to foster the development of or growth of physician organizations. And the goal is to slow the movement of physicians to hospitals. That if physicians have more viable physician organizations that have a chance to be more economically successful, there's less reason to become employed by a hospital. Some payers are doing this in selected markets simply by buying practices so that they can work with them and keep them away from hospitals. Some insurers have also provided financial and technical assistance to independent practices, particularly support for health information technology. Again, making it more viable for physicians to stay independent. There have been some very interesting examples of very advanced patient-centered medical home models where the primary care physicians, often joined in a pod with other primary care physicians, have incentives to control overall spending for the patients in their panel, not just primary care spending. And these are done on an upside-only basis, so that if they do well, holding spending below a benchmark, they get a reward. If they do not do well, they're not penalized, just nothing. They just don't get a reward. There's some policy options to foster physician organizations, and one is loans or grants for physician practices to establish infrastructure. And the Medicare ACO program does some of this, where there is some capital financing support for physician-sponsored ACOs, and in fact they will allow smaller organizations, if they're physician organizations, to participate in the ACO program. A very specific policy option would be to eliminate, or at least reduce, the higher Medicare payments for physician services in hospitals. And the rationale for this is that this is an artificial incentive for hospitals to acquire practices, because if they can get paid for physician services by Medicare more than the physicians can if they're independent, well, this just gives the hospitals greater ability to raise the compensation for physicians if they'll be employed by the hospital. There are downsides to it that I think Margot mentioned, as far as some of the additional overhead expenses that hospitals need to cover. And MedPAC has made recommendations over time, which has tried to navigate these two forces of being specific for the types of physician services that often people still go to those old offices the physicians were in outside the hospital campus, saying that's okay not to have overhead. I want to say a few things about antitrust policy. Had hoped Marty would be here to say more about it, but I think that antitrust policy, which has had success in addressing hospital horizontal mergers, we need to develop policies on hospital acquisition of physician practices. And I think the reason that we haven't had much activity, specifically, the Federal Trade Commission's success by challenging an acquisition of a primary care practice in Boise, Idaho, was not based on vertical combination issues, even though I think the state attorney general's suit was brought on that basis, but it really was one based on that this would lead to a monopoly in primary care in some parts of the Boise area. And I think the reason that perhaps antitrust policy hasn't developed is that we don't really have much of a research base to have confidence that we understand what are the implications for prices and quality of hospital acquisition of physician practices or greater employment of physicians. And I think, fortunately, I think the research base is developing. I just put a link on my slides for a study that's really just out in working paper form, but seems to have very impressive results. And a few concluding thoughts. I think there are some of the upside in the developments in financing and delivery that involve greater coordination and integration do have a downside in likely leading to increasing consolidation. And my perspective on this is that we should proceed with coordination, integration, proceed with these developments, get the very high potential long-term benefits in better care and more efficient care, and address the consolidation through other policies rather than just not have additional consolidation. I think there are additional opportunities for market approaches to offset the impact of growing provider consolidation and leverage. And government has a very important role in fostering these market approaches. And one thing that I haven't spent time on, which is rate setting, should be seen as a stick in the closet if market approaches turn out not to be doing the job. And probably the most interesting thing to watch in the rate setting direction is what's happening as the Maryland hospital rate setting system kind of moves into the 21st century and finds ways to work in this area of integrated financing and delivery. Thank you very much.
Thank you so much, Professor Ginsberg. This is really thought-provoking. I just want to take a moment and ask both of you a couple of questions. But before I do, I wanted to remind everybody that we will be uploading these slides and the archive of the entire presentation webinar on reporting on health. and also that this is really a good time for you to ask your questions by typing a note into the chat or question field on your control panel. So, question for both of you, what has been the impact of the Affordable Care Act on these trends? Has it really accelerated consolidation and physician mergers?
I don't think we really know. I think we can definitely see in the data that the number of mergers has been on the rise since the Affordable Care Act passed in 2010. But whether those changes are due to the Affordable Care Act or due to forces that were already in place is a little hard to know. I mean, one explanation I'd heard about the big surge in 2010 is that a lot of these hospitals were kind of holding off and they were going to wait and just see what happened with the legislation before they moved. So I think, when you talk to the hospitals, they mention the Affordable Care Act a lot, but it's not entirely clear that that's the only reason why this is happening or whether, it really can take too much credit.
Yes, the Affordable Care Act probably contributes in some ways, but we have to realize that the Affordable Care Act, like most legislation that affects Medicare, was really, consisting of some very controversial parts of expanding insurance coverage, and it was the years trained leaving the station where lots of relatively non-controversial Medicare provisions could become enacted at the same time. And I would characterize the various provisions on payment reform, on ACOs and bundled payment, to be in that latter category. It was really just in the air. There was a lot of private sector activity in Massachusetts and Minnesota, other places experimenting with these approaches. And to me, just the Affordable Care Act, with its non-controversial section, just pushed it forward somewhat by making Medicare a player in it.
Thank you. And just to take this down to the consumer level, why should a consumer who's shopping for health care, looking to have a surgery, care about these hospital mergers and the mergers of physician groups with hospitals?
Well, unfortunately, the effect that these mergers have on what consumers pay for health care is not very visible to consumers at all. Because basically, the main effect of the mergers on prices is, higher negotiated prices with insurers, and that's going to lead to both higher insurance premiums and higher employee contributions to employer-based coverage, which employees often aren't that aware of, and to some extent higher patient cost sharing when enrollees get sick. So in a sense, it affects consumers fully, both directly through higher patient cost sharing and indirectly through higher premiums for coverage.
So I'm going to turn to some of our participants here. Are there differences in hospital consolidation trends between nonprofit and for-profit institutions?
That's a good question. My sense is that the consolidation that leads to much higher concentration in a market is often among nonprofit hospitals, because for-profit hospitals tend to be in a lot of different areas. On the other hand, I would say that for-profit hospitals are often in areas that are very small. They're in rural areas or in small cities. So some of these areas are monopolies already. They only have one hospital. So I don't know if I should have answered the question, because it's hard to be definitive on that.
Margot, did you have any thoughts on that one?
I just haven't looked at it closely enough to be able to answer in a comprehensive way. I think most of what we're seeing is in the nonprofit space, but I think that there have been some acquisitions by the larger for-profit chains as well.
And I wanted to return to a remark that was made earlier in our presentation. What different type of contracting would be needed to have a more stable network? And that's a question from Lisa Alafiris of KQED.
Well, I think one possibility would be, I have a sense that as far as contracting between plans and physicians, that often they uh, either the plans or the physicians can push for change at any time. So if contracting was standardized, particularly if it followed calendar years, that would probably, so that physicians commit and plans commit that this contract will, go through an entire calendar year. I think that would lead to more stable networks and probably would make it a lot easier for consumers to be then, choosing a plan based on the network that they're advertising, and then having confidence that that network will be there throughout. Even with hospital contracting, which is more structured and has definite starting and end dates, conforming that to the calendar year might also make them more stable for consumers.
There may also be some regulatory approaches on this end. The federal government just put out a proposal that what they want to do next year for plans on the federal exchange, so the individual plans, is they're going to require health insurers to keep accurate network lists that are updated and audited every month. And for every month that they're out of compliance, they'll have to pay a fine. It will be harder for state insurance regulators to impose fines like that unless the legislature gives them that authority. But I think there are ways in which federal and state regulators may be able to just require more accuracy about those network lists, so the customers, when they're trying to decide what doctors are in what networks, will have a little bit more accurate information than is normal now.
In fact, what Margot mentioned is a great example of regulation fostering market forces. In a sense, as opposed to regulating the details of when contracts have to start and end, if the regulation is just saying that you're on the hook for having accurate networks each month, that might lead to insurers figuring out what type changes in contract practices would work best under this scheme, where there's a lot more emphasis on network adequacy than there used on network transparency than there used to be.
Professor Ginsberg, this is a question from Dan Browning, and you sort of touched on this at the end of your presentation. He says data dramatically shows very little price growth for hospitals over the past few years, despite some waves of consolidation. Doesn't that undercut the arguments that consolidation is leading to a non-competitive level of price growth?
Well, I thought the data is that price growth is not negligible. I think some of the data from the healthcare HCCI, I forget what it stands for,
Healthcare Cost Institute.
Yes, Healthcare Cost Institute, which Marty Gaynor, before he joined the FTC, was the chair of. I think at least in a number of years showed that the overall spending trend was down, but that price, almost all of it was from price trends. I think that the greater pressure on Medicare, of Medicare squeezing hospitals on Medicare payment rates, I think that has led to a slowing in price increases for private insurers, because the hospitals have responded by cutting their costs more vigorously. There's a growing literature on cost shifting, which to many people's surprise have shown that when Medicare squeezes down on prices, that the hospitals respond by cutting their costs, and that there is no cost shift. So anyway, that's one thought about, I'm sure price increases have slowed somewhat, that could be behind it.
I actually have asked Marty this question, and he said that one thing that's important to realize is that even though the number of mergers is on the increase, that the number of transactions that's happened is still, as a percentage of the overall hospital market, is not a large percentage of the overall hospital market. So we're in this period of spending slowdown, which I think people don't fully understand the reasons for, but we guess that there are probably many reasons for. And so it may be that these kind of larger forces are overwhelming whatever smaller effects may be happening as a result of these mergers. So I think it's to be seen, but it's possible that price increases are happening as a result of some of these mergers, but we're sort of just getting erased by the larger forces that are happening throughout the market.
We have a question from Roger Smith from the Center for Health Reporting. Is there any incentive for insurance companies to acquire hospitals?
So I was just in Pittsburgh last week where that has happened, where the largest insurer in the market has purchased the sort of second largest hospital chain in the area, and I think it's kind of a great experiment to see whether that's going to be successful or not. It's just not very common. I think what we see more often are hospitals that want to become insurers and not so often insurers that are interested in purchasing hospitals. I don't know, I'm curious what Paul would think. I think they're just very different business functions, and it may not be the sort of thing that many insurers want to get into that business, but a lot of things are changing right now, and it may be something we see more of.
Yes, I've answered journalists' questions about Pittsburgh for a long time, and I continue to say it's very idiosyncratic situation, and I just do not expect this to be the start of a trend, and I really haven't seen anything like it in other places.
And this is a question from Lindy Washburn. She wonders, do you have any tips for reporting on FTC consideration of these deals? Lindy hasn't really covered the FTC as an agency. What kind of materials are submitted as part of the review? Maybe just give a quick overview, and we can also follow up after the webinar further with Lindy.
It's been a while since I've looked at these. I don't want to say something and say it wrong, but my understanding is that there are only certain kinds of transactions that the FTC looks at. So they have to be of a certain size, and they have to be of a certain the institutions have to be of a certain proximity to one another. And I don't know that a lot of those submissions are public before the FTC generates its ruling. Is that right, Paul?
I think so. Yeah, I think that it's a very significant decision within the FTC which mergers to challenge and which ones, most mergers are not challenged and just allowed. So I don't think until there's a challenge, I don't think you will really see anything. The other thing I can mention is that the FTC enforces two distinct laws, and the one on deals with consolidation is bounded by, is driven by what's called the rule of reason, that the FTC has to convince the courts that the merger is bad for consumers. Whereas there's another law, which is about price fixing. And there, the FTC can just prosecute price fixing. It doesn't have to prove that it was bad for anyone. It's considered a per se violation of the antitrust law. It's just illegal, period. And it has very important implications as far as what physician organizations can, who are not clinically integrated and are not taking risk, their ability to negotiate with insurers as a single entity.
Once the FTC does decide to challenge a merger, though, then there becomes quite a nice paper trail of documents of, the FTC's rulings, and then if often these things proceed into these sort of like quasi-court debates, and so there are documents that are submitted by both sides and expert testimony that's submitted, and you can, if there's sort of one of these ongoing challenges, then you really start to be able to see a lot more about the arguments that are being made on either side and how the hospital understands the merger to affect the market and how the government thinks it will affect the market.
So we have about 1 minute left, but I think that our two speakers have offered to stay a little bit longer. We still have some really good questions here. But for those who need to end their participation promptly at 11, I wanted to share that we'll be sending you a survey and ask you to fill out your quick thoughts, and also to let you know that as part of that email, you will also get information on our next webinar, which will be looking at King versus Burwell, and that will be taking place on June 16th from 1 to 2 p.m. Eastern Standard Time. So we're going to continue with our questions for another little bit, and then please look out for that survey and take a moment to share your replies. And also, if you write stories that include some references to things you've learned here and you want to share them with us, we would be delighted, and you can write to us at editor@reportingonhealth.org. So the next question is from Janet Heinrich. She says, what do you see as the role of states in managing markets?
Oh, that's a great question. I think a lot of public policy in managing markets is going to be left to the states, or I should say, the states will step up and do it. We've even in antitrust law, that some antitrust challenges to mergers are brought by state attorneys general. And as I mentioned, Massachusetts has got significantly involved in the regulation of plan and provider contracting. Of course, network adequacy. There is a CMS dimension for the plans sold on the federal and state exchanges and the public exchanges, but many states have their own network adequacy policies. So I think a lot of the interesting developments as far as policies that deal with market consolidation and competition will be at the state level.
And we have a note from Jean Jadhone, who writes, as a local reporter who has seen physician practice after physician practice join forces with the largest hospital in the region, and she puts join forces in quotes, how can we cover this in an understandable way? We know the hospital system is becoming a monopoly, but I think people feel they have no control over this.
I think you have to cover, I used to be a newspaper reporter in New Hampshire during a period in which a lot of this was happening, and I think you sort of have to cover it one at a time, and then you also have to cover it in a large way. So, I think each one of these things that happens, like I would cover it and explain why it's happening and explain how it fits into the larger trend, but then I think it is worth doing these kind of step back pieces from time to time that just tell people like, oh wow, like there are no independent primary care practices left in this market, or very few. And also to sort of report on what the consequences of those are, whether it's more difficult for patients to get access to care, or whether their out-of-pocket costs are going up as a result of only having choice within one system. I don't know that there's a lot that your reporting can necessarily do to reverse the trend, but I think there are a lot of stories that you can tell that really describe what's happening and explain the consequences. And if you do it along the way, then maybe people will start to understand it before there's no one left.
So this is a question from somebody who's deeply immersed in healthcare, and I'll ask you in answering it to translate some of the terminology. This is from Patrick Pine, who writes, I manage a self-funded Taft-Hartley, and like many, we have ASO arrangements with major carriers to access or, quote, rent their networks. We are concerned that when insurers and hospitals combine, it leaves the ASO clients in a no-win position. Is that something you've considered given the large number of self-insured plans?
Well, maybe I'll take a stab at this. I think the questioner is correct that that basically greater consolidation is going to impact self-insured plans in the exact same way, almost the exact same way as it affects fully insured plans, because it really comes down to the prices that the whatever entity has formed the network has to pay for the services of providers. And so this has broad effects throughout the healthcare financing system.
We have a question from Amy Trent, who asks, does Margot have any advice on looking into a healthcare system's purchase of an insurance company? My hospital's a nonprofit, so I won't have the 990s on the purchase for a while.
Good question. It depends. There may be more information that's available sooner depending on how that purchase was financed. So if there was any debt that was taken out, nonprofit hospitals often have to publish their bond prospectuses, and I included a link in my slides of at least one place where you can look at those. So I think that's one good place, because if they have to borrow money in order to make this transaction, they have to present to the bondholders all kinds of information about what they're planning on doing and also what the state of their current finances is. That can often be a faster way to find out what's happening inside of a nonprofit than waiting for the 990.
Usually when hospitals acquire an insurer, they're acquiring a very small insurer, and often it's really just to get their license, to be able to write insurance. And this is really part of the movement towards population health value-based care for a significant delivery system to want to compete in the market by often offering its own health plan. And probably for all hospitals that do that, there are even more that actually form partnerships with a particular insurer in their market, again, to offer a product which is branded with the healthcare system's brands, but is administered by the insurer. So, the actual acquisition of an insurer by the hospital is not likely to make the insurance market less competitive. Actually, it might make them more competitive because it might be a more viable competitor to the major insurers than the little insurer that they acquired. But it's really a part of this movement towards limited networks and value-based approaches to healthcare financing.
And now a final question from Gianna Magnoli, who asks, Paul, you mentioned a need for more antitrust policies for vertical integration acquiring physician practices. What review and regulation exists now? Is there regulation for hospitals acquiring primary care practices or just specialty practices?
Yes, well, antitrust policy is a very different animal than most other types of policy, because rather than having Congress or state legislature write laws and then or write executive branch agencies write regulations, typically antitrust policy comes about when the Federal Trade Commission or Department of Justice or a state attorney general challenges a transaction and brings forward their evidence as to why this transaction is a bad idea, and then the courts will make a decision as to whether to prohibit the merger or allow it. And usually that case and the precedent it's set, that's what establishes policy. So in a sense, when I say that we don't have a policy about vertical integration yet, it's really because we have not had a challenge, at least by the FTC, to such a transaction and a decision by a court. And I suspect that the FTC is waiting until there's more of a research literature and if the literature turns out to suggest that these vertical consolidations raise prices, then it will bring a case at that point. And depending on the decision made in that case, that will have established a policy. It could also happen when a state attorney general challenges a transaction as well, even though that would just apply for that state, but that would also really lead to influence thinking of other policymakers in the antitrust world.
I lied when I said that was the last question because somebody added one more, and I thought this was relevant. Joseph Magruder asks, where does a system such as Kaiser fit into this picture?
Well, Kaiser, by being so thoroughly integrated and, being a combination of a health plan, a hospitals, and a physician group, it's really not affected by what's happening in the rest of the market, except insofar that often places where Kaiser is very important, like in California, Kaiser's efficiency and currently attractiveness to physicians and to many enrollees is actually a constraint on the exercise of market power by the other providers in the market. Indeed, I do a lot of interviewing in California for site visit research projects, and typically if I ask a hospital leader, who's your most important competitor, they won't mention the other hospital in the community. They'll mention Kaiser Permanente. So in a sense, I think Kaiser kind of functions independently. They don't have large enough market share anywhere to consider it an antitrust issue, and they don't grow by acquisition. They grow by internal growth and attracting more enrollees.
Well, I want to thank our two fabulous panelists, Margot Sanger-Katz and Professor Paul Ginsberg, especially for being gracious enough to stay a little longer to answer the really excellent questions from this very smart group of participants. Just a reminder that we will be sending you a survey, and we hope you'll take a moment to reply to it, and also that on June 16th, we will be having another webinar on King versus Burwell, the upcoming Supreme Court decision. That's going to be either from 10 to 11 Pacific time or 1 to 2 p.m. Eastern time on June 16th, and you can sign up for that through our survey. Thank you again to all of you.